Hello and good evening. Thank you for joining the DYSIS Smart Colposcopy United States webinar. My name is Brent Palmisano. I'm with DYSIS Medical. I'll be hosting the call tonight with Dr. Jeff Livingston, who we're pleased to have. Dr. Livingston's the CEO of MacArthur Medical Center in Irving, Texas. He serves as a medical director and board member of Texas Health Surgery Center in Bedford. He's the former OBGYN chair at Baylor Medical Center Irving, and he now serves on the medical board for Texas Health Resources Harris Methodist location. Dr. Livingston, many of you may know, is an advocate of the use of social media in healthcare, and has been featured in the USA Today, Wired Magazine, and Voice of America. On that note, he's also in the Dallas chapter for Entrepreneurs Organization. So as you can tell, DYSIS is a newer technology, and Dr. Livingston is an early adopter. And we're really excited to have him share with all of us his perspectives on the technology. A few housekeeping notes before we get going. Please understand that you're muted, but you can chat in questions, and we'll ask those questions at the end of the presentation. And before we get started, I just want to take a moment to explain, for those of you that may be new to DYSIS altogether, what exactly DYSIS is. It is a next generation digital video colposcope that has an advanced cervical imaging system. With that, it standardizes just about every aspect of the colposcopic exam, and it allows you to conduct a normal colposcopy and adds an easy to interpret, adjunctive, color-coded map that objectively quantifies the intensity and the duration of the acetyl whitening process to aid in identifying potential areas that you may want to biopsy. When you think about the full construct of the DYSIS Ultra device, it includes a medical grade computer, a digital camera, integrated acetic acid application that homogeneously applies 1.5 cc's on the cervix, and it has a touchscreen interface that you can also share the exam with the patient via that interface, via that monitor. That said, it is with great pleasure that I hand the next 30 minutes over to Dr. Livingston, who will share with you his experience of implementing DYSIS into his practices. Dr. Livingston, over to you.
Thank you, Brent, for that kind introduction. I really appreciate it. And just for the audience members, I'm just a regular private practice OBGYN, just like you. And this is MacArthur Medical Center. This is our team at the top right picture. We're a multi-specialty practice in the Dallas-Fort Worth area. We basically have surround the Dallas-Fort Worth airport in our 4 locations. We have 17 OBGYNs, 3 amazing pediatricians, 1 family practitioner, and we also incorporate mid-level providers into our practice in that we have 1 nurse practitioner, 3 physician assistants, and 2 certified nurse midwives. One of our core values of our company is innovation. And as we incorporate new technologies into the practice, we evaluate whether it will make our lives better, the patient experience better, and the care that we provide better. And so we were early adopters of Esure, in-office hysteroscopy, endometrial ablation. We adopted the robot into our practice. But when DYSIS came around, I immediately wanted to try it. This looked like something that we could really integrate into our practice. And what I'm going to share with you for the next 30 minutes is exactly how we did that. So our agenda for this talk is basically to talk about why colposcopy needs to improve, to give you some clinical data behind how we came to those conclusions, and then to share with you some case studies from my own personal experience and practice to help illustrate how DYSIS can improve the care that you provide to your patients. We'll start off with a case study. So this is a 45-year-old white female. She was referred to me for an ascus HPV positive PAP. This is what her cervix looked like before the application of acetic acid. As you can see in the cervix, there's a lot going on there. We've got the Nabothian cyst down at the bottom. We've got some abnormal vasculature, and then we've got some metaplasia on the top. I think it's important that everybody watching this sort of look and analyze that cervix and determine how you would proceed if she was your patient in your office tomorrow. This is 30 seconds into the traditional colposcopy. The acetic acid has been applied, and we're starting to see the typical changes of the cervix when acetic acid is applied. Here we are at 124 seconds into the procedure. So 2 minutes into the procedure, imagine this was your patient. I'd like all listeners to identify on the screen where you would place your biopsy. Once we applied the DYSIS map, it clearly showed the lesion at 12 o'clock. The biopsy ended up demonstrating invasive squamous cell carcinoma of the cervix. For me, this was a game-changing experience. I can honestly tell all of the listeners that I would not have biopsied that spot. I don't remember my mental state at the time. I may have been distracted by the Nabothian cyst, by the abnormal vasculature, sort of the white spot right to the right of that, and the fact that this is sort of removed from the transformation zone. We're up and away. But the DYSIS map guided my eyes into finding the right spot, and ultimately this patient's life was saved from the diagnosis made on this day. So what's going on in the world of colposcopy? So we've got traditional colposcopy. The patients are still coming to us. But as we're spacing out the frequency of routine pap smears, most gynecologists are experiencing a decrease in the volume of their colposcopies. As with any skill set, if we don't do it as often, our skill begins to decline. But as our skill may be declining in colposcopy, we're extending the intervals between pap smears. We're not seeing these patients as often. At the same time, the screening tests are becoming more and more sensitive. Well, what does that mean for us practicing OB-GYNs in the community? It means if we're not going to do pap smears as often, and we're going to extend the intervals between screening, when we have the patient in our office, we have the responsibility to get it right. If there's a tool that can help us make our colposcopy more effective, then that's something we need to consider adding to our practice. This is DYSIS colposcopy. So here on the left side of the screen, we can see the machine. And on the right side of the screen, we can see the value that it provides all of us in practice. So at the top, this is a demonstration of the DYSIS ability to detect lesions. We all want to think of colposcopy as a completely objective study, but the reality is there's some subjectivity to it. It depends on the talent and the experience of the colposcopist. But even in the most experienced colposcopist, as I'm going to show in future slides, there's variation in interpretation. What DYSIS does is once acetic acid is applied to the cervix, it quantifies the acetowhitening process. This increases our ability to detect lesions and improve our biopsy efficiency. The DYSIS system also improves the documentation process for colposcopy. And in a future slide, I'm going to show you an example of the beautiful images that DYSIS provides that could integrate seamlessly into your electronic health record. At the bottom, we talk about DYSIS creating a better patient experience. And for me, the decision to adopt this technology into MacArthur Medical Center, this was really, really key. Colposcopy before DYSIS was something that we did to the patient. Once we adopted DYSIS, it became a procedure that we do with the patient. The patient becomes a part of the procedure because they're able to visualize the procedure from start to finish. And while we're discussing complex issues like cervical dysplasia, the transformation zone, and showing the areas of biopsy, the patient can see and understand exactly what's happening, decreasing her fear, reducing her anxiety, and making her a more engaged patient. So this is a standard view of the cervix under traditional colposcopy, and acetic acid has been applied. As I move through, I ask the listeners to evaluate this cervix on their own as though this patient was your patient. At the end of the procedure, where we are now, I ask the listener to mark the areas on the cervix that you feel need biopsy. Where are the areas that are most concerning to you to mark the high levels of concern? Once we apply the dynamic spectral imaging to the cervix, it's going to quantify the absorption and the retention of acetic acid in HPV infected cells. We can then apply the DYSIS map. Remember, it's important that you already in your mind have marked your areas for biopsy. DYSIS does not replace traditional colposcopy. Here we apply the map, and you can see that 2 areas of high risk were identified. Both of these areas will be biopsied. This is the improved Colpo study, and I had the pleasure of participating in this. And the point of this study was to analyze the outcomes of the adoption of DYSIS into a traditional medical practice. We compared the use of DYSIS and how it affected the care that we provide our patients. This was done in my site, as well as 8 other clinics across the country. 26 providers participated, and just under 900 patients were counted. As you can see on the screen, when we compare the before and after, we increased our detection of CIN2 by 44%, and we increased our detection of CIN3 by 50%. Back to what we talked about earlier in the presentation. When we're doing colposcopy, we need to get it right. What this paper demonstrates is we improved our detection of CIN2 and CIN3 by adding DYSIS to our traditional colposcopy. This is an example of the level of documentation that is provided by DYSIS. This is a system called SmartTrack. On the left side of the screen, we see the patient's first colposcopy, and we can compare that to a subsequent study done on visit number 2. For patients that are undergoing conservative management, we can compare their colposcopy from the past to their colposcopic exam that's done now. And I know you may be laughing, but this is how I documented my colpos in the past in my chart. I think we can all agree that the SmartTrack system offers a much improved system over my hand drawings. Bringing the patient into the experience is such a key tool, and so allowing her to see and observe and to become a part of the process reduces her anxiety, reduces her fear, and helps her understand exactly what's going on. In this example, the doctor is communicating the findings after the procedure. I like to have the patient participate during the procedure. So while we're undergoing the exam, I walk her through exactly what I'm seeing and exactly what's being done. You can see on the right, a beautiful report is generated that includes all of the pertinent clinical information, as well as high resolution images that can be seamlessly integrated back into the electronic health record. DYSIS is approved through the FDA as an adjunctive imaging map applied after traditional colposcopy. What do I mean by that? I mean that we do not replace our traditional clinical experience with colposcopy. We still perform the procedure and we make our decisions on where biopsies need to go. We then use DYSIS as a tool to improve our exam. What we talk about is DYSIS is addition and not subtraction. Let's do some case studies. So this is a patient with a high-grade PAP positive for HPV-16. And what we're going to demonstrate here is the challenge of finding a high-grade lesion when there's a large area of low-grade appearing abnormalities. This was a market study where we asked physicians to mark with an X the area that they felt needed to be biopsied after viewing this image. So here's the acetic acid being applied. We're going through the process. And then we asked the physicians to study the cervix and mark any, none, or all areas that needed to be biopsied. Here are the areas that the physicians selected. As you can see, there's a wide variation in choice. We have a lot of attention here between 12 and 1 o'clock. We have one person identifying an area at 3 o'clock, one at 6 o'clock, and 3 physicians focused at the 7, 8 o'clock. Again, this is not criticism of anybody. I put myself in these shoes, and I may have made a different choice as well, because although it is an objective experience doing colposcopy, there is some subjectivity to it, and there's variation in interpretation of the exam. So now we'll apply the DYSIS map as an adjunct to our traditional colposcopy. As you can see, DYSIS was able to find the high-grade area inside of the large area of low-grade abnormalities and identified the high-risk area needing the biopsy. The biopsy ultimately confirmed CIN3. Metaplasia can often cause difficulty for colposcopy. We think of it as finding a needle in the haystack. In this case study, is a 29-year-old smoker with a low-grade PAP abnormality. After traditional colposcopy, the physician's initial interpretation was that this cervix was normal and no biopsy was needed. And I ask all of the listeners to evaluate the top screen and determine if they are in agreement. Would you biopsy this cervix with this history and this colpo exam? If you would biopsy, where would you place your biopsy? As a part of market research, we asked 7 physicians to interpret this colposcopic exam. 5 physicians interpreted this exam as a normal cervix. 1 physician interpreted as a low-grade abnormality, and 1 physician interpreted as a high-grade abnormality. As you can see, the locations for where the biopsies needed to be all varied. Some physicians recommended 0 biopsies, and some physicians recommended up to 4 biopsies. Once we apply DYSIS to the image, we can see that a high-grade lesion is located at 6 o'clock. Biopsy of this area showed CIN3, and the patient underwent a LEAP procedure. All clinicians are often faced with a post-LEAP cervix. Cervixes after a LEAP procedure are often difficult to interpret under traditional colposcopy. The scar tissue changes the appearance of the cervix, making the exam much more difficult. In this case, this patient had 2 previous LEAP procedures, and it had been 2 years since her last procedure. Her last 3 PAPs are listed below: a low-grade PAP, followed by a negative PAP, followed by a high-grade PAP. Here's her cervix after the application of acetic acid. And following the process that we will throughout this presentation, I asked each listener to identify the area that you would biopsy if this were your patient in your office tomorrow. And again, the challenge of the post-LEAP cervix is clear here. Once we apply the DYSIS map, we can see the high-grade area appearing at 7 o'clock. It's easy now that the map is there, it's easy to go back and look at the left side of the screen and think, well, of course, that's where it was all along. I know that I would have found it. I can speak from my experience, having done many procedures with DYSIS. I'm often surprised at the areas that appear that my eyes didn't see before. This is a 31-year-old African-American female with a high-grade PAP. The initial impression of the cervix after the application of acetic acid was that this cervix was normal. The clinician performing this exam had made the decision, based on traditional colposcopy, that no biopsy was needed. Now we'll apply the DYSIS map, and you can see that a very, very small area right at 6 o'clock and off to the right of that are noted. Biopsies confirmed CIN3, and the patient underwent a LEAP procedure. This is a 29-year-old African-American female referred for ASCUS HPV positive PAP. After application of traditional colposcopy, the impression was that the cervix was normal. I ask again each listener to identify for themselves where would you biopsy this patient if she were your patient in your office tomorrow? Please mark on the screen where you think the biopsy should go. After we apply the DYSIS map, we have two areas that are identified. A biopsy at 7 o'clock confirmed CIN2. Unfortunately, this patient was lost to follow-up. This represents a good example of a lesion appearing outside the transformation zone or in more remote areas of the cervix. This is a 44-year-old African-American female referred for ASCUS HPV positive PAP. After performing the traditional colposcopy, the physician recommended no biopsy, and the clinical impression was that the cervix was normal. I ask each listener to, again, for yourself, make the determination of where you believe the biopsy should go. After we apply the DYSIS map to the cervix, a high-grade lesion is seen at 7 o'clock. This is a 23-year-old Hispanic female with a high-grade PAP. On the right side of the screen, we can see the acetowhitening areas. The physician identified two areas for biopsy marked 1 and 2. Now we'll apply the DYSIS map to the cervix. As you can see, although the physician identified the high-grade area marked by the number 2, the actual high-grade lesion was slightly to the right of the area marked by the physician. While it's possible that that was the intent of the mark, we cannot say. Using DYSIS, we're able to much more precisely mark the areas needing biopsy and perform our biopsy in the right spot at the right time. This patient ultimately had CIN3 and underwent a LEAP procedure. This is a 30-year-old Caucasian woman referred for ASC-H-PAP. We can see on the right of the screen the acetowhitening after the traditional colposcopy. The clinical impression was that the cervix was normal and one area was identified for biopsy. We'll now apply the DYSIS map to the cervix. And you can see a high-grade lesion is noted near the area that was marked, but just below the area that the physician marked for biopsy. The biopsy confirmed CIN2 and the patient underwent a LEAP procedure. I hope these case studies illustrate to everybody listening that we have an opportunity here, and it's an opportunity that's critical. As the sensitivity of screening tests increases and the interval between pap smear increases, we have a responsibility as OBGYNs, when given the opportunity to perform a colposcopic procedure, we have the responsibility to get it right the first time. Innovation in colposcopy is needed, and DYSIS presents an amazing opportunity for all of us to adopt this technology into our practice to provide better care for our patients. I'll now turn this presentation back over to Brent, and we can answer any questions that come from the audience.
Great, thank you, Dr. Livingston. That was tremendous. I hope you can hear me loud and clear. A few questions. Good. A few questions that are present here are the first one. Tell me a little bit about the transition from traditional colposcopy to DYSIS. How big of a learning curve is it? What should the expectations be in your estimation?
That's a great question. I mean, all physicians, anytime we adopt any new technology, any new medical device, there's always a learning curve. And interesting with DYSIS, the learning curve are things that you don't necessarily expect. One of my biggest challenges was learning to place and remove the speculum that's required for DYSIS. It's a slightly different shape and a different curvature than speculums that we traditionally use. And that just took some practice to learn how to insert it comfortably and to remove it comfortably. There's a little bit of learning curve of learning to attach the machine to the cervix. And I can kind of relate it to docking the robot for robotic surgery, although much easier than that. DYSIS will provide a clinical team that will come and help any doctor that wants to integrate that into the practice, and they're going to be right there by your side. It's only going to take 2 or 3 cases to really feel comfortable with the speculum and docking the machine. The rep will be there to help you manage the technical aspects of how to work the buttons and the touch screen. So that should be a pretty low stress moment. Other than that, the doctor is just going to have to learn how to trust the technology as well. This is why it's so important that we really emphasize the point that this doesn't replace traditional colposcopy. You proceed as you always did and you make your clinical decisions. Then you apply the DYSIS on top of that. And what physicians are going to find is just going to make their life easier.
Yeah, it's a great clarification on the adjunct technology and you making the decisions versus the map doing it.
Right.
Another question came in on following patients over time. You touched on this a little bit in the presentation, but can you expand on that a bit more now?
Yeah, no, I think that's really, really key. And so most of us, if you're my age, you grew up with paper charts and really bad hand drawings of cervixes. And back also at that time, we were very, very aggressively treating patients with CIN1 got cryo of the cervix, and leaks were much more common. As we've learned more about HPV and the progression to cancer and the high rate of resolution, we're seeing much more conservative therapy. So we now have patients that are choosing conservative management of things like CIN2. Tracking those cases becomes much more important. If all we have are words typed into an electronic health record or a hand drawing, it's very difficult to compare true changes in their exam over time. DYSIS offers something called Smart Track, which adds the ability to not only see the images, but a video playback of any of their previous colposcopic exams. So if we're going to manage a patient conservatively, the best thing we can do is have a really accurate view of their previous studies. That way we can track their progress or a worsening in their condition in subsequent exams.
Perfect. That was great. And that is it. There's a few other questions that are more individualized that we'll make sure we get back to each of you appropriately. Again, thank you all for joining. Dr. Livingston, thank you as well. Enjoy the rest of your evening. I can see you still have a little bit of sunlight being in Texas. It's getting dark here.
A little bit.
We'll go ahead and sign off. Be safe, everybody. Thank you again, and we'll be in touch. Good night.
Thank you.